Hello, I'm Steve Primack from Oregon Health and Science University, and welcome to this online talk series presented by the STR. This talk will focus on blunt thoracic trauma. I have no relevant disclosures. In this talk, I will review the imaging features of injuries due to blunt thoracic trauma, while the emphasis will be on CT findings. Pertinent radiographic findings will also be discussed. The talk will be divided into the sections listed below. Due to time restraints, I will not be able to cover skeletal trauma in this presentation. Traumatic aortic injury is the most critical diagnosis in the blunt thoracic trauma patient. The chest radiograph still is often the first imaging study obtained in the trauma patient. In most cases, a negative chest X-ray excludes aortic injury with a negative predictive value of 98%. However, positive predictive value is quite low. Several findings have been described radiographically to suggest mediastinal hematoma. Mediastinal widening is the classic finding. However, there's really no precise way to define this, and most often apparent mediastinal widening is due to low volumes, vascular congestion, mediastinal fat, or just related to the AP technique of the chest radiograph. The more specific findings on the radiograph include right paratracheal density equal or greater density than the aortic arch, should raise suspicion for mediastinal hematoma. If the aortic arch is poorly defined, particularly in a younger patient, that should raise suspicion. Left apical cap due to extrapleural hematoma tracking above the apex. And then NG tube or tracheal deviation to the right, or very difficult finding to make downward displacement of the left main bronchus is a finding of a contained mediastinal hematoma. However, in most cases, the mechanism of injury usually determines the need for CT. CT findings in traumatic aortic injury have been well described. Keep in mind, periaortic mediastinal hematoma is present in most cases, and then most injuries occur in the proximal descending thoracic aorta, just distal to the origin of the left subclavian artery, so that's where most of the evaluation should be paid attention to. Several direct findings have been described. Pseudoaneurysm is the classic finding in traumatic aortic injury. One may see a focal intimal flap. There may be abrupt caliber change of the thoracic aorta. Occasionally one will see extravasation of contrast indicating a significant surgical emergency in a traumatic aortic injury. And the more recently described is minimal aortic injury, where one might just see some subtle wall irregularity or a small filling defect within the aortic lumen. So let's look at a few cases. It's an 18-year-old involved with an MVA, and we see obvious mediastinal widening. There's increased density of the right paratracheal region. There's loss of definition of the aortic arch as well as a left apical cap. And on several CT images, we see extensive mediastinal hematoma in a periaortic distribution. There is a focal intimal flap, as well as a pseudoaneurysm in the proximal descending thoracic aorta. On sagittal reconstructed images, we see a large circumferential pseudoaneurysm, abrupt caliber change of the aorta as well, indicating significant traumatic aortic injury. This individual sustained a high-speed MVA. We see a large layering left pleural effusion consistent with a hemothorax. There's a clear-cut left apical cap, loss of definition of the aortic arch, indicating a high suspicion for traumatic aortic injury. Axial CT image shows significant periaortic mediastinal hematoma, and then a classic appearance of a pseudoaneurysm. Sagittal reconstructed images. Image shows a pseudoaneurysm on the undersurface of the proximal descending thoracic aorta. Note the acute angle with the undersurface of the aorta. Different patient. Couple of images here. A small amount of mediastinal hematoma in a periaortic distribution. We see a intimal flap and a classic pseudoaneurysm indicating traumatic aortic injury. In this patient who had severe trauma, we see multiple right-sided rib fractures with subpleural hematoma, large area of pulmonary contusion. The left hemidiaphragm is elevated, and that turned out to be a diaphragm herniation. And then more subtle, we see slight widening of the aortic arch, but really no widening of the right paratracheal region. And then this is an example of subtle but real depression of the left main bronchus. CT images in this case, the first finding we want to be able to appreciate is that there's an aberrant right subclavian artery. Additionally, we see periaortic mediastinal hematoma, as well as a traumatic pseudoaneurysm. So indeed, this patient had traumatic aortic injury in addition to several other traumatic injuries. This 42-year-old man who sustained a MVA, we see right paratracheal widening and increased density. Also note that the right lung is small in volume. Several CT images, so that we see the apparent mediastinal widening is actually due to right lower lobe and right upper lobe atelectasis. This is the top of the pulmonary artery. And then what is this focal outpouching of the proximal descending thoracic aorta? Note that there's no evidence of mediastinal hematoma in this case. If we look at oblique reconstructed images, we see a smooth outpouching of the proximal descending thoracic aorta. Note that there's obtuse angles with the undersurface of the aorta. And this is an incidental ductus bump, not to be confused with a traumatic aortic injury. So if we look at these side by side, note that the ductus bump is an outpouching classic location of a traumatic aortic injury, but has very smooth obtuse margins with the undersurface of the aorta. Compare that to the traumatic pseudoaneurysm, where we see acute angles with the undersurface of the thoracic aorta. Two other examples, ductus bump on your left, small outpouching obtuse angles with the undersurface of the aorta. Compare that with the traumatic pseudoaneurysm, where we have outpouching and very acute angles with the aorta. 47-year-old sustained MVA, we see widening of the right paratracheal region with increased density, so high suspicion for mediastinal hematoma. A couple of CT images, we see significant mediastinal hematoma in a periaortic distribution. However, if we look lower down, we see a burst fracture and the thoracic aorta is normal throughout, so no evidence of traumatic aortic injury and a mediastinal hematoma due to a spine burst fracture. This patient sustained a high-speed MVA. We see definite periaortic mediastinal hematoma, and in the mid-descending thoracic aorta, we see this subtle irregularity of the aortic wall. And this would be an example of a so-called minimal aortic injury, where often these are followed conservatively, but important to recognize. And in this patient, we see a CT scan from 3 days following the injury. We see decrease of the mediastinal hematoma and a normal appearing aorta, so resolution of this minimal aortic injury. Another patient, we see evidence of periaortic hematoma, a small amount of that, and then the aorta throughout is completely normal. So we can trust that this periaortic hematoma is very, very likely due to something else with a normal aorta. Notice here's a very common finding due to pulsation artifact in the ascending aorta, a normal finding. This patient had a CT for other reasons 8 days later, and we see an example where the aorta lumen is sharply defined and the small amount of mediastinal hematoma has resolved. The 63-year-old woman had blunt trauma due to being stepped on by a horse. In this case, we see a fair amount of mediastinal hematoma, although note that this is all just immediately above the aortic arch. And then a very abnormal appearance of the proximal right brachiocephalic artery. And on reconstructed images, we see a classic appearance of a pseudoaneurysm at the origin of the right brachiocephalic artery, indicative of a traumatic tear. 64-year-old woman status post-MVA. We see a fair amount of mediastinal hematoma, but in this case, it's in the tracheoesophageal region and also in the region of the azygous arch, but really no periaortic hematoma. And then we actually see a pseudoaneurysm involving the azygous vein at the level of the azygous arch, and this is an azygous arch tear. Very unusual injury, but one that does occur and should be recognized if you come across it. So moving on to pulmonary parenchymal injuries, which are basically pulmonary contusions and pulmonary lacerations. Pulmonary contusion is a lung injury combined with hemorrhage and edema. It's usually evident at presentation and should always be present within 24 hours of trauma. They tend to be peripheral, they cross segmental boundaries. Classically, they present as poorly defined ground glass opacities or consolidation, and air bronchograms are rarely evident within pulmonary contusions. And then on imaging, whether it be radiographically or on CT, there's usually some clearing of pulmonary contusions within 2 to 3 days. So here's two examples. On your left, we see peripheral non-segmental ground glass opacity, very classic for pulmonary contusion. And here's a more focal consolidative opacity in the periphery of the left lower lobe, indicative of pulmonary contusion. Pulmonary laceration is defined as pulmonary parenchymal tear with rupture of alveolar walls. They present as thin-walled cystic spaces with or without fluid within the cystic spaces. There's almost always surrounding pulmonary contusion, and on radiographs, the lacerations are usually obscured by the pulmonary contusion. So here's a classic example. We see extensive ground glass opacity, albeit fairly well defined, and multiple cystic air spaces indicative of pulmonary laceration. A pneumatocoel is defined as a laceration that's filled with air, and that typically presents as a cyst or cavity. A hematoma or a hematocoel is a laceration that's filled with blood, and that typically appears as a well-circumscribed nodule. Keep in mind that hematoma can persist for several weeks or months, so it can be confused with a solitary pulmonary nodule. Few examples of lacerations. Here we see several displaced right-sided rib fractures, patchy ground glass and consolidation in the right lung. And on CT scan, we see adjacent to one of the rib fractures a well-defined consolidation with a couple cystic air spaces, indicative of pulmonary laceration. Lacerations can be divided into several types. Type 1 is the most common, and it's a compression injury, and typically is an intraparenchymal consolidation or ground glass with a cystic space. Type 2 is a shearing mechanism and classically are in the paravertebral region, as in this case we see a small pulmonary laceration in the right paravertebral region in the right lower lobe. Type 3 is from actual tearing mechanism, typically from a fractured rib, as in this case we see a rib puncturing the lung, and we see extensive pulmonary laceration in the left lung. Another finding on this one that you want to recognize is the endotracheal tube tip is in the left main bronchus. Here's a presentation. We see a large pulmonary laceration, large cystic space with extensive ground glass and somewhat of a thick-walled laceration at presentation. On an 8-day follow-up, we see clearing of most of the contusion and much of the fluid within the laceration. We see a large, thick-walled cyst or cavity in the left lung. This is the same patient at presentation. We see an air fluid level within this pulmonary laceration, a relatively thick wall. 8-day follow-up, we see decrease of contusion and more thinning of the wall of this large laceration. This patient, we see a large area of contusion and laceration initially. On the CT scan, we see a well-defined contusion with multiple lacerations within it. And in a 3-week follow-up, most of this contusion has dissipated, and we see a well-defined nodule consistent with a pulmonary hematoma. So when we see pulmonary parenchymal opacification, in most cases what we're looking at is pulmonary contusion or laceration. However, keep in mind that aspiration and atelectasis are extremely common in the trauma patient. So if we see a large area of ground glass, fairly well defined with multiple cystic spaces within it, that for sure is going to be a large area of pulmonary contusion and laceration. In this patient, we see a classic appearance of pulmonary contusion in the periphery of the right upper lobe. However, when we look more inferiorly, there's extensive tree and bud ground glass opacification throughout both lower lobes, a pattern very characteristic of aspiration. This patient will have a classic appearance of right lower lobe atelectasis in this trauma patient, sharply defined lateral margin, essential collapse of the right lower lobe. Follow-up the next day has significant decrease in the right lower lobe atelectasis, and we see this high attenuation, well-defined structure here, which is actually an aspirated tooth responsible for the atelectasis. This patient who just sustained blunt chest trauma, really no other findings of trauma within the chest, but we see this fairly well-defined ground glass consolidative opacity with some cystic spaces in it. So keep in mind that not everything is a contusion. This was followed and turned out to be an incidental lung cancer in this trauma patient. Moving on to hemothorax. Classically, pleural fluid that's a hemothorax will have high attenuation values, usually 35 to 70 Hounsfield units. The hemothorax is often heterogeneous. We occasionally can detect active bleeding with contrast extravasation into the pleural space. One may see fluid hematocrit levels. Keep in mind that delayed hemothorax occasionally occurs, particularly with multiple rib fractures. And as the blood clots in a hemothorax, we may get an appearance of so-called fibrin balls, and this may mimic pleural tumors on occasion. So here's a classic case, somebody with multiple rib fractures, and we see this very heterogeneous right pleural fluid collection with low and high attenuation pleural fluid, very classic for a large hemothorax. This patient who sustained multiple rib fractures, and this is a delayed presentation of hemothorax, and we see these focal areas of high attenuation, so-called fibrin balls from clotting blood within the pleural space in this hemothorax. Moving on to pneumothorax, keep in mind that only 45 to 70% are going to be detected on the supine chest radiograph. Classically, we'll look for the visceral pleural line, although this is often not evident on a supine AP chest radiograph because the air is going to be more anterior and not demonstrating a visceral pleural line laterally. We look for a deep sulcus sign or subpulmonic lucency in the supine patient. If one sees subcutaneous gas plus rib fracture or fractures, there's probably pneumothorax present, just not evident on the chest radiograph. Tension pneumothorax is a clinical diagnosis. However, if we see certain findings, we can very highly predict that it's a tension pneumothorax, particularly depression of a hemidiaphragm is going to be the most specific finding of a tension pneumothorax. If we see mediastinal shift or splaying of the ribs, we should also suggest that there might be a tension pneumothorax. In this patient, we see a classic deep sulcus sign, so a lateral lucency over the right hemidiaphragm laterally, as well as this subpulmonic lucency, fairly sizable pneumothorax likely present. In this patient, the visceral pleural line is very, very subtle. There's also this lucency projecting over the lower right hemithorax, very subtle, difficult to appreciate. And we see actually a very large pneumothorax anteriorly on the CT scan in this patient. This patient has a very large left pneumothorax with near complete collapse of the left lung. And then when one sees this depression of the left hemidiaphragm, that indicates that this is under tension in this intubated patient. Briefly on pneumomediastinum, one has to be concerned when one sees a pneumomediastinum in trauma. Could there be a rupture of esophagus, trachea, bronchi, but also just ruptured alveoli can lead to pneumomediastinum. Pneumomediastinum can also occur from air dissecting from neck or retroperitoneal injuries. But keep in mind, statistically, over 95% of cases of pneumomediastinum are from ruptured alveoli. And this has been the so-called Macklin effect, where air from alveolar rupture dissects centrally along the interstitium. Classic case of pneumomediastinum, blunt chest trauma. We see extensive pneumomediastinum tracking into the neck. There's actually some air in the inferior pulmonary ligament here, and this was from a blunt chest trauma from a faceplant with a snowboarder. Moving on to tracheobronchial injury, they're very uncommon to detect, and they typically occur in very severe trauma with many associated injuries. Bronchial tears are usually within 2 centimeters of the carina, the right being more frequent than the left. Tracheal tears are usually longitudinal and usually in the posterolateral aspect of the trachea. Iatrogenic tracheal injuries can occasionally occur from traumatic intubation. Tracheobronchial injury is important to recognize because if unrecognized, they can lead to stenosis. Findings that we look for is basically air where it shouldn't be, pneumothorax, pneumomediastinum, subcutaneous air, and there's often a lot of it. Another finding would be that the lung fails to re-expand following appropriate chest tube placement for pneumothorax. The fallen lung sign is a well-described finding, particularly on the chest radiograph, and that's a finding we see in bronchial tear. If we see an extraluminal position of the endotracheal tube, that clearly means a tracheal tear. However, also look for cuff overinflation may suggest a tracheal tear. And also keep in mind that direct visualization of tracheobronchial tears is often quite difficult, and it's really the other findings that we look for and then a high suspicion for it. Here's a patient with a large pneumothorax and the fallen lung sign. So typically a lung, when it collapses from a large pneumothorax, should collapse towards the hilum and not fall with gravity. Chest tube was placed in this patient appropriately in the pleural space, but there was still a persistent large pneumothorax. At bronchoscopic evaluation, this patient was discovered to have a right main bronchus tear. And this patient at presentation had extensive bilateral subcutaneous gas, had multiple chest tubes placed. With chest tube placement, had a persistent right pneumothorax as well as extensive pneumomediastinum. And at bronchoscopy, this patient was discovered to have a bronchus intermedius tear. This is the same 63-year-old woman we discussed earlier, stepped on by a horse. We see subcutaneous gas, we see pneumomediastinum. On the CT scan, we see the pneumomediastinum as well as this focal defect and extraluminal gas posteriorly in the trachea, and this was discovered to be a tracheal tear. High-speed MVA, we see extensive bilateral subcutaneous gas, extensive pneumomediastinum. And then the other finding one wants to detect is this balloon is quite overinflated. So that should raise suspicion for a tracheal tear. On CT scan, we again demonstrate the extensive pneumomediastinum, the overinflated balloon cuff. We really can't see the tracheal tear here, but this patient was explored and had a large posterior tracheal tear. Moving on to diaphragm traumatic injuries. They can be termed lacerations or herniations. Left side more commonly identified than the right at approximately a 3-to-1 ratio. Frequently, other traumatic injuries may distract from detecting a diaphragm tear, so one has to have a high level of suspicion to detect these. Now, there's usually other abdominal injuries, so occasionally a diaphragm injury may be discovered while exploring the abdomen surgically. And it's important to detect these injuries because delayed herniation has a very high mortality if it occurs. Chest radiograph is usually abnormal with diaphragmatic injuries, but is frequently nonspecific. There's often obscuration of the hemidiaphragm. One may see what looks like an elevated hemidiaphragm, which is actually the herniated portion of the abdomen. One looks for a herniated bowel or herniated stomach. One may see an abnormal course of the NG tube. Radiograph, which would be classic for traumatic diaphragm hernia. So we see an abnormally elevated stomach, and then we look at this very narrow waist or collar of the stomach as it herniates through the diaphragm. CT scan, several findings have been described in the literature. Classically, you can see a focal discontinuity of the diaphragm that indicates diaphragm injury. One obviously looks for herniation of abdominal contents. A collar sign is a finding seen in herniation. The dependent viscera sign is a finding of herniation. In most cases, one would see focal diaphragmatic thickening and inflammatory changes or fluid adjacent to the diaphragm for an acute diaphragmatic injury. In the literature, the sensitivity of CT ranges from 70 to 90% with specificity greater than 85%. So also got a few examples. This is an example of a diaphragm herniation acutely, and we see a collar sign and dependent viscera sign. So here's the collar sign where we see the intra-abdominal portion of the stomach is more anteriorly, and then the narrowing or wasting of the stomach as it herniates through the diaphragm, and then the intrathoracic portion of the stomach is more posterior. And that's been termed the dependent viscera sign. So the stomach, while it's in the abdomen, should be more anterior and not abutting posteriorly, but as it herniates into the thorax, it tends to layer against the rib cage. And on the chest radiograph, we look at this, we can see the collar sign on the chest radiograph indicative of herniation. In this example, we see a classic example of the collar sign. So the anterior portion of the stomach here is the intra-abdominal portion, and then the herniated portion of the stomach is more posterior. And then this is an example of the dependent viscera sign where the stomach is abutting posteriorly. We may detect lacerations without herniation. In this case, if we look at a nice normal right crus, smoothly tapering, whereas the left crus has an abrupt termination, a lot of fluid and inflammatory changes at the point of the laceration. A couple other examples of diaphragmatic herniation. We see a small focal portion of the kidney is herniated on the right, and you see an obvious defect in the diaphragmatic crus. And in this patient, we see a large amount of colon that's herniated and the abrupt termination of the right crus indicative of a torn crus with herniation of colon. Sagittal and coronal reformations are very important in evaluating diaphragmatic injury. Although we can detect most of these with axial images, we're clearly limited by the plane of imaging, and using sagittal and coronal reformations definitely increase conspicuity. So in this example, it's an old case, we see this large amount of omentum or fat next to the left heart border, and is that intrathoracic normally, or is that a herniation? And if we do a sagittal reconstruction, we see an obvious defect in the diaphragm with herniated omentum, so a clear-cut diaphragmatic hernia. This patient, we see what looks like an elevated left hemidiaphragm, but this certainly could be a hernia on the left. We do axial images in this patient. We see what looks like a dependent viscera sign. The stomach should not be abutting the posterior ribs. And is this a collar sign, this little focal indentation? If we look at multiple coronal reformatted images, we see here the collar sign on the coronal view. So this is clearly a herniation of the stomach through the diaphragm. And then on multiple images, you see this abrupt cutoff of the diaphragm indicating an acute injury of the diaphragm. Most common pitfall for diaphragm injuries would be incidental bacterial hernias, which occur particularly at increasing frequency in older patients, not as common in younger patients when we see them. And here we see somebody with bilateral incidental bacterial hernias, and the hint that these are not acute is there's really no other finding of trauma in that region, no blood, no inflammatory change in that region, and they're smooth and tapered. 61-year-old individual status post-trauma, we see a large amount of fat next to the right heart border. And on the coronal reformatted images, we see a defect anteriorly in the diaphragm and a clear hernia anterior. So this would be a very unusual location for a traumatic diaphragm hernia, but a classic case of a Morgagni hernia. And if we look at the chest radiograph on this patient, this appears as a right pericardiophrenic angle mass, and in that Morgagni hernia is in that differential. So one last case, 73-year-old woman was in a severe motor vehicle accident, had severe chest pain, and we see here extensive subcutaneous gas bilaterally. If we look on lung windows, a few findings here. We see air in the pericardial space, and this has been termed the empty pericardial sac sign. addition, we see a very unusual appearance of the heart, where the apex of the heart is projecting more posteriorly as opposed to anterolaterally. And then we see what's been termed the collar sign, where we see this narrow waist of a portion of the heart. And so this is a classic appearance of traumatic pericardial rupture. So very unusual diagnosis, but critical to make this diagnosis because prognosis is very, very poor without surgical intervention. So in summary, aortic injury is clearly the most important finding that we look for in imaging blunt thoracic trauma patients, but other injuries for sure can lead to increased morbidity and are really important to detect as well. And I do thank you for your attention in this online course. Thank you very much.